leprosy. Leprosy is a great imitator. It is a competitor for secondary syphilis. So my aim is to determine the various atypical presentations of Hansen's disease. As we already know typical presentations, now atypical presentations are yet to learn. A lot to learn is there. It is a prospective and observational study in my OP. So leprosy presents with varied manifestations in post-elimination era. We should have an open eye for early diagnosis. It is emphasized in many studies that late diagnosis due to quiescent nature, multibacillary cases, lack of active case detection, increase in migrant people, social, cultural, economic inequalities are the main reasons for this rise in leprosy. Hereby, I present 5 cases of atypical presentations of Hansen's. My first case, case 1, it is LL Hansen's disease with ENL, but mimicking Kikuchi's disease. He is a guy of 58-year-old male patient, farmer by occupation, came to the OP with raised reddish erythematous macules and papules for the back of the chest, nodule or the groin region and also knee region, and or the front of the chest also he has erythematous macules and papules. While taking the thorough history, we came to know that he has been diagnosed as Kikuchi's disease, has been treated with the Kikuchi's disease since been long time. They have diagnosed, outside practitioners have diagnosed by taking the biopsy from the skin biopsy and the lymph node biopsy, and he diagnosed as histiocytic necrotizing lymphadenitis, that is Kikuchi's disease, and he has been treated on this on and off. Now, 1 month ago, he has come to the OP. Then we have thoroughly examined the case. There were no hypopigmented patches. There was no cold sensation lost. There was no nerve enlargement at all. But as our professors have a eagle Hansen's disease, we has kept DDs as Hansen's disease and also Kikuchi's disease, and we sent one lymph node. That is not the lymph node actually. That is a nodule present over the groin region and also knee region. One biopsy from the groin region, one biopsy from the skin biopsy we have sent for the as a keeping DD as Hansen's disease, and it came to be our surprise ENL, erythema nodosum leprosum type 2 leprosy reaction. He is in type 2 leprosy reaction. He came with us with these nodules, and immediately we started MD and within 6 months, of duration, now he is on 6th month of 6th blister. Now I can show after treatment pictures also I have kept. All the nodules have been cleared, macules have been cleared, nutritionally he is well. So this has been treated as misdiagnosed as Kikuchi's disease. This is the first case. We have taken triple S smear also, ZN strain we have done. Then there is 5+ of Mycobacterium leprosy in the slit skin smear also. This is the slit skin smear. We can see the Mycobacterium leprae. 5+ cases, 5+ is there. We have done in my OP only, this ZN smear. This is the biopsy report we got, and it has been told that nodular granulomatous inflammation centered around neurovascular bundles of superficial and deep dermis. The granuloma consists of foamy macrophages and lymphocytes. Numerous neutrophils dot the granulomas accompanying moderate amount of nuclear dust and fibrin. The dermo-epidermal junction is spayed by granulomatous infiltrate. However, few neutrophils can be seen within the epidermis and spongiosis can be seen. Impression is erythema nodosum leprosum, that is type 2 leprosy reaction. And this is the before treatment picture where he was on Kikuchi's disease treatment. I think Krishna Rao sir knows better about the Kikuchi's disease than dermatologist. Then after the treatment of MBMDT, we got the patient as all the maculopapular rash has been cleared, and he is physically well now, and he is on the 6th blister pack now. This is the nodule before the treatment, and the nodule has been treated with MBMDT very well. And also we have kept the steroids also. We started with a 50 mg OD, and we slowly tapered the dose as he was in fever and the joint pains also in ENL. So this is the case history as already explained about this. Peripheral nerves are not enlarged, not tender. Motor nerve examination was very normal. Hairs, nails were normal. Eye examination was normal. Genitals were normal. There was no history of epistaxis, no history of slippage of chapels, No hypopigmented hypoanesthetic patches found all over the body. Cold sensations were intact. No history of photosensitivity. No oral ulcerations was seen. By taking this history, we can't go to the Hansen's disease unless we have the experience of this kind of cases. So this is my first case, which was misdiagnosed as Kikuchi's disease. So my second case, he is very young fellow who has been misdiagnosed as fibroma, mucinosis. Since 5 years, he has been treated with mucinosis symptomatic treatment. He is a 25 years old male patient, came with raised nodules on the bilateral ears. Raised nodules, he has been taken biopsy from the raised nodules and it has been proved to be fibroma outside. So he has been on the treatment for fibroma. Now he came to the OP of me because of cosmetic issue, not because of anything else. He came with the cosmetic issue that nodules are not being cleared. So we had the first DD as Hansen's disease. He is a 25 years old male patient and we had first DD as Hansen's disease and we took the skin biopsy from the ear nodule with 3 mm biopsy. 3 mm biopsy has taken, we have sent to dermatopathologist and it came to be borderline lepromatous leprosy. And we started on the MBMDT for this patient also. And there was a drastic response. The cosmetic issue has been cleared and he has been treated as fibroma. This case has been misdiagnosed and now he is happy with I think 7th blister pack is going on. He is 24-year-old male patient. And also one more thing I have to say about this patient is there is hypopigmented patch over the buttock region that has been missed. The thorough examination of the case is very much needed because hypopigmented patch can be present in the buttock region, which can be missed out. So we counsel the patient that is there may be was because he has nodules on the ears. Why he was checking? Why he is checking the buttock region? He was very reluctant, but we counsel the patient to see the buttock region also. In the buttock regions, there are small hypopigmented patch and cold sensation were lost on the hypopigmented patch. And we took the biopsy from the ear nodule also and also from the patch. Both came out to be leprosy and we started MBMDT for this patient. And we kept as a DDs as Hansen's, lupus vulgaris, mucinosis, and sarcoidosis. Biopsy brought lepromatous leprosy. This is my second case. And case 3, leprosy mimicking lupus vulgaris. She is a 50-year-old female, came with erythematous plaque over the left cheek. Since 5 years, they have been treated for lupus vulgaris cutaneous TB. And she was not regularly on the treatment. She came to the OP. We had first, we took the biopsy from the plaque itself. You can see this biopsy picture also. We have taken 3 mm punch. And the biopsy shows that lepromatous leprosy and foamy macrophages has been found in BMDT for this patient. And she is in follow-up now. And she is been responding for the treatment. She has been treated since 5 years as lupus vulgaris for cutaneous TB. TB drugs also she is taking irregularly. She came with a plaque now. Biopsy has been proved leprosy. So we stopped the TB drugs and we started on leprosy drugs. She is responding well. And also we ruled out lupus vulgaris by taking the X-ray, CT scan. All the routine examination have been done to rule out the TB. This is my third case. And fourth case is very important case, very much misdiagnosed case. We thought it has tinea corporis, and we were shocked to see this patient as lepromatous leprosy case. She has been complaining of round red lesions all over the body associated with itching. She is telling very much itching, and also she has groin lesion. So any dermatologist with a groin lesion, also polycyclic borders with a central clearing. First diagnosis our fungal infections itself. Then the itching is there, fungal infection is there. We also have given meconazole and clotrimazole for 2 weeks. And she has been coming since for 2 weeks. 2 weeks she is coming for 2 months here. Then our professors have been told that to have the cold sensation and nerve enlargement checked. She had ulna now enlarged. We planned for nerve biopsy, but we could not correlate with the neurologist, and some way it has been missed. but we took the biopsy from the skin. It came as a lepromatous leprosy with ENL. Again, type 2 lepromatous reaction, which has been thought as superficial fungal infection, has been treated, but no, it came as a lepromatous leprosy. Then we got an idea that very important to see cold sensations, hypopigment patches, and nerve enlargement for every case which is suspicious. And we have started MBMDT. There were foamy macrophages and we ENL also. So we have started steroids also for this patient. Gradually, we are tapering the patient, and this case has been following up. We are following up this case. This is my case 4. Case 5. This is a very nice case. Like we were very much sure that it is granuloma annulare or erythema multiforme lesions. She herself have been telling that I have been taking NSAIDs, I have been getting fever, NSAIDs and fever. She is leading us to the misdiagnosis as erythema multiforme. And she has also palm lesions. We also on the palm, I lost that photograph. And our other diagnosis was granuloma annulare. There was no cold sensation lost actually on the lesions. Cold sensation were intact, and nerve enlargement was not seen in this case. But we have one DD as leprosy. We have taken the biopsy from the intralesional biopsy, and we have sent for the biopsy. It came as borderline tubercular leprosy, and we started on MBMDT, and the lesions were gradually decreasing now. And these lesions were only seen in the photo-exposed areas, as which is mimicking at other photo-aggravated conditions. But as it is very granulomatous, and our OP has many Hansen's disease, we has kept DD as a Hansen's disease first, and it came to be a Hansen's disease. And it is very early diagnosis. Since 1 month only she is getting this. So we are very happy that we have diagnosed very early, and we counsel the patient to take the medicines very regularly and have the regular follow-up for this patient. And the patient also was very happy that that she has been diagnosed very early, and she is 30 years old, very young female person. So we are happy, and the patients also were counseled that this disease is a chronic disease, but early diagnosis has been made. So treatment is going on. Regular follow-up is necessary. If there is any fever or dapsone reactions and all, we have explained very clearly when to take the dapsone, when to take rifampicin. We have supervised her and counseled her. She is very happy now, and she is in regular follow-up. This is my case 5. This is my last case, and my discussion is leprosy is a great imitator which have various clinical presentations mimicking many other diseases in the field of medicine. Being at the poor immunity spectrum of the disease, lepromatous leprosy can cause physical morbidity and disability, leading to social stigma. Physicians must have a knowledge regarding this disease, unusual presentation, so that early identification and prompt treatment of the disease can be done in order to prevent the complications and also its impact on the patient's life. There was no conflicts of interest on this regards. And thank you very much. Thank you very much for this opportunity for me. Yes, ma'am. So I end up here with my PPT.
Okay, first, it's a pure dermatological manifestations you have presented.
Yes.
That's okay. Would you like to see your title? You have written that mimicking mycobacterium leprosy. That's your title, no?
Yes, ma'am. Yes, ma'am.
Mimicking mycobacterium leprosy, a great imitator.
Yes.
That English language is not all right. You said you are presenting in the award session, no?
Yes, ma'am. Yes, ma'am.
Mimicking mycobacterium leprosy, a great imitator. Means you are the meaning of this sentence will be something else is mimicking mycobacterium leprosy.
Okay.
So you should say that mycobacterium leprosy, a great imitator. That's sufficient.
Okay.
You should cut off
okay,
that.
Sure, ma'am. Sure, ma'am. I will make changes.
Okay, so that is one. Second, I want to see the face of your first case. It's a pure dermatology manifestation only you have put. So I want to see the face.
Face of the first case. Actually, this is I'm presenting as award paper, ma'am. They did not accept for the face. But I have an
the
image,
face.
ma'am. Yes, yes, ma'am.
Yes, lepromatous leprosy, apart from the skin lesions, can be erythema nodosum or anything. But it is
yes, ma'am. Yes, ma'am. I will show the face of the patient.
When you say imitator, you should put, you should tell lessons learned in each case. You see.
Yes, ma'am. Yes, ma'am.
So, what is the key point that will make you suspect apart from the lab?
Okay, ma'am.
Lab is okay. That we are not concerned. Clinicians, no?
Yes,
So,
ma'am. Yes, ma'am.
unless you suspect, you will miss it. So, here, because you have put only skin, you have to discuss the differential
Yeah.
diagnosis of these
Okay, can you
lesions.
see this patient, ma'am?
Face, first show me the face. Because for a clinician in lepromatous leprosy, face is important. No?
Ma'am, I have shared this.
Skin lesions, erythema nodosum can happen in many conditions.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
One of which is Hansen's disease, which is
Yes, ma'am.
not the common cause.
Yes, ma'am.
Definitely, that is not the common cause.
Yes,
So,
ma'am.
what will make you suspect is facial features. Later
Yeah.
age group. Now, age group is in the late 5th or 6th decade, you said. So,
Yes, ma'am.
so
I'm sharing this face, ma'am, but are you, can you
no,
see,
I'm
ma'am?
not seeing the face. I'm not seeing.
Oh.
So, what are all the key points, key message? Otherwise, you say, I thought erythema nodosum. Okay, everybody agrees it is erythema nodosum. It is one of the cause for Hansen's. What is great about that? No.
Yes,
So,
ma'am. Yes,
pathologist is giving you the diagnosis. You are not giving a lesson to the colleagues.
yes, ma'am. Yes, ma'am.
So, you should tell that in the context of so many conditions can happen. And one thing, late age group, unusual sites, no?
Yeah.
Erythema nodosum, classical ones associated with vasculitis and criculitis, they do not occur in the areas like groin.
Yes, ma'am. Yes, ma'am.
Unusual locations. Age group.
Okay.
The, older, this patient is older than
Yes,
the
ma'am. Yes,
classical age of the autoimmune disorders and where this happens. Then facial features.
Okay.
I'm sure if we carefully look, we will find a bulbous ear and things like that.
Yes, ma'am. Actually, I'm able to find that, but I'm not able to share in this. Actually, ma'am, I'm not able to share the face. I have
You
kept in the
should
desktop,
put
but I'm
it in
not
your
able to.
award paper, because if you say award paper, you should
Ma'am.
give key message.
Okay.
See, that key message is not there. It is like a pathologist presentation, no?
Okay.
It's a clinician's presentation, no? You are a clinician.
Yes.
No?
Yes, ma'am.
So you should put the face. You can take one of the limbs.
Okay.
And at the end of that case, you should say lessons.
Sure, ma'am.
If erythema nodosum occurs in the 5th decade,
Okay.
and other features of the classical autoimmune conditions where it occurs is absent.
Okay.
And the lesions are seen in unusual locations, clubbed with the bulbous ear.
Okay.
Those are the three key points you should put at the end of your case one. So that is the lesson from that case.
Yeah, sure, ma'am. Sure, ma'am. Thank you.
Second case, you said
Fibroma, ma'am.
Fibroma.
Yes,
Why
ma'am.
do you think it is fibroma?
Ear nodules, ma'am.
But they are, even though I agree, I am not a dermatologist, but you see, fibromas, do they have this much broad base?
Actually, clinically, it is not.
Fibromas generally are slightly pedungulated.
Okay.
So compressible, no?
Okay.
And this location is very unusual location.
Yes,
Otherwise, you get this kind of ears in poisoning by one drug. That will toxin root. I'm not getting the name now because it's not come. Nose and the ears become nodular like this. It's a vasospastic poison. You just check that, you will get it.
Yes, ma'am. Sure, ma'am.
Yes, I'm not dermatology discussing and I'm not practicing dermatology. I am not getting it. But this kind of thing happens specifically in the ear and nose. It's a vasospastic agent. I think it is a toxin, which is akin to no, that is a poison. A poison will produce this kind of lesions. Fibromas, this is not the typical nature. Second, you know that eczema.
Yes, ma'am.
The eczematous lesions will look like this. So you should tell the difference, ma'am. You see, you should know, we are clinician, no, especially dermatology is like neurology.
Yes,
if the clinician misses, everybody will miss.
Yes, ma'am. Yes, ma'am.
So you should tell the point. Here, the base is not narrow.
Yes,
It's
ma'am.
not soft and compressible. It
Yes,
is not in the usual location of a fibroma. No, fibromas are usually seen in the neck.
Yes.
Ear is an unusual location. Whereas this kind of a ear will be seen in oozing eczema
Yeah.
and poisoning by that drug which produces acral necrosis. Acral necrosis, limbs, ear. Ear is typically picked, and ear will, in some fruit, when they eat it, they get this. Because I learned it only in my MBBS days, so I am not able to recall, but it's typically like this. So you should highlight the differential points. What happens for us now these days?
Yes.
Doctors do not spend even 2 minutes.
Yes, ma'am.
You see, MRI will show a lot of lesions. I had done my case in the PPT in the last session. MRI brain will show a lot of lesions. So if you diagnose demyelination, some vasculitis, you will correlate. So this is only vasculitis. Where brain will show lesions in leprosy.
Yeah.
So you think it is Kikuchi disease or some kind of vasculitis which is producing the ENL? Do the MRI of the brain. Brain will show lesions. So it'll say agree, and patient will go into a terrible disease. So clinical point is very important. So here you should highlight the broad base, location, and the bulbous earlobe. This if you so you should tell the points that somebody missed it.
Yes, yes.
But you will not miss it. Because this looks more like leprosy only.
Yes, yes, yes.
You understand, ma? So
Yes,
you say that clinical training is becoming poorer. So eyes do not see what the mind does not know.
That's right.
So to me, this will be first diagnosis, leprosy only. You see. So last class also I told about an engineering student. He went away for 3.5 years from medical college everywhere. Finally went into Ayurveda thinking that allopathy science cannot help. Ayurvedic physician referred the patient to me. It was a classical leprosy. So that is the reason I said our our chief of this White Army that I will do a presentation on Hansen. So last week I did it. So you should tell how somebody missed it as fibroma.
Okay.
Why they thought, because you tell the pathologist, I am thinking of fibroma. Pathologist will find reasons and say it is fibroma.
Oh, yes, ma'am. Yes, ma'am.
Unless you see the organism, for a pathologist, it is all some kind of permutation combination, match it with the clinical picture.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So that will happen. So you should tell the location and the nature of the lesion. You palpate it. Is it compressible and soft, which is the nature in fibroma?
Fibroma.
Here it is juicy.
Yes, ma'am. Yes, ma'am. Oozing and eczematous lesion as you told.
That is not at all a feature of fibroma.
Yes,
so this is actually a typical case of Hansen's disease.
Yeah. Misdiagnosed.
Terrible decline in clinical sense.
Yes, ma'am. Yes.
So that's a teaching point.
Yes,
what is happening to us? People say that create manpower to fill gaps in to take care of rural India. So I used to think when these talks are going, you create manpower who are poorly equipped, very dangerous.
Yes, ma'am. Yes, ma'am.
If you don't have a doctor, it is good enough. But if you have a doctor who kills you, it's very dangerous. So that is happening. So quality is very important. And young people should insist that merit should be the only criteria. At least in medicine. Other subjects, okay, because you are going to handle the most precious possession of somebody, that is his life. So in this case, he will tell it's a typical case.
Yes.
So here the highlight point is very inefficiently equipped clinical sense.
Yeah, ma'am.
You see, there is a statement that if all investigations fail, go back and examine the patient. That is the current motto. Don't examine the patient. Do all investigations. Everything is failing, then open your eyes and go back.
Okay.
That criteria, that you put as the point here.
Okay, sure, ma'am. Thank you.
Case, unfortunately, maybe less exposure to such cases.
Yes.
So you will put point number 1, fibroma. Then that poison you pick up as a typical one. Eczema. We'll put eczema, oozing eczema, Hansen's disease, fibroma, and that poison.
Yes.
3. I am sure you also know. You are a young boy, no? Forensic medicine book, it is there.
Poison, acky fruit is one thing, but that is pediatric patient diarrhea will come. Necrosis is one is thing, warfarin drug will cause it. Poison, envy.
No, it produces nose, ears,
Spider, you mean spider poisoning, ma'am? Spider.
Not the boy, you see. Ergot.
Ergot poisoning. Yeah, vasoconstriction, and it will cause a digital limb gangrene.
Typically the ears. So you will
Yes,
put
ma'am. Yes,
at the end of this case, you will put a PPT showing eczema, Hansen's disease, fibroma, and ergot poisoning. Point
Ergot
number
poisoning.
1, 2, 3, 4. So that is the
Okay.
lesson you will give with this case. You see,
Yes,
our
yes.
paper time will be less, I know, but key point is more important than telling the diagnosis. Diagnosis, you have already said all are leprosy, so don't have to tell it.
Okay.
But you highlight the keys.
Yes.
So this is a typical case, but that point will be very enlightening because everybody knows that there's a terrible decline in standards, terrible dangerous diagnosis, and we kill more people than save.
Yeah.
So that it will be a very important lesson.
Yes.
So that is with the case number 2. Ergot.
Yes.
You read, you will be surprised. It is exactly like this.
Yes, ma'am. Yes, ma'am. Yes.
Yes. Next is the third case. You said the raised nodule. What is the third case?
Yeah, lupus vulgaris.
Lupus vulgaris. That I agree. But that lupus lesion, I am using the word of Professor Tambaya. Have you heard of Professor Tambaya? Madras Medical College, a famous dermatologist. You heard of?
Yes.
Tambaya sir, no? He's a very great dermatologist. He found out the drug treatment for poisoning with this.
Yes.
He used that. Are we audible? Do you know Professor Tambaya? Very famous physician who found out the natural remedy for the eczema which happens with the plant that grows near the, what is that, Kuamar in Madras. Tumbai plants, that one plant is there which is very itchy dermatosis, and they develop psychosis, and they die also when in contact with that thing, that yellow flowers plant. So this grows in Tumbai river, that Kuamar, and doctor died with the psychosis. And that time sir went there, and he found that in areas where the white flower Tumbai plant is growing, this one doesn't grow. So biological antagonism was detected by him, and then he did so many ICMR projects, and the active alkaloid was identified, and that is the treatment for that plant which produces itchy dermatosis, yellow flower, small plant, very weed-like it grows. So that person is Professor Tambaya, a very famous man. And this lesion, lupus vulgaris, what are all the atypical features in this case? So I always tell in neurology, I'm not a dermatologist, but in neurology, hard signs, soft signs, and odd signs. You see, in this patient, if you see, you have got some odd features. You see, lupus vulgaris will not have a raised center like this.
Yeah.
It will have a very dirty looking irregular margin. So you are dermatologist, you should describe. So you should say, okay, this is in the face. And it's a very, so that is a feature which is a hard feature. Lupus vulgaris can occur in this area. Sight is okay. But what is odd feature? Odd feature is the center will not be raised in lupus vulgaris, whereas center will be depressed, and margins also will not be like this in lupus vulgaris.
Yes, ma'am.
It's not a neurologist meet. In the neurologist meet, they may not ask. Because dermatology, no, they will ask. So lupus vulgaris will have a very dirty looking, irregularly raised margin. So you should say, this patient has got a lesion in the face and nowhere else, no nerves are thickened. So, so by location and solitary lesion, you are right in thinking lupus vulgaris. But what is the odd feature? Odd feature is center will never be raised in lupus vulgaris, and margins will not be edematous like this, but they will be verrucous. They will be very like a wart. It will be very hard, irregular, wart-like lesions. Today I am thanking Tambaya sir because when I was doing MD medicine, he used to take class between 6 a.m. and 7 a.m. morning. So, but somehow he did not like medicine students. He's a very wonderful teacher. He used to teach us when we are doing MD like an undergraduate. But he used to tell me that this girl is like propionic acid bacteria. She cannot be removed from the class by surgical wash. Surgeon's wash doesn't remove the propionic acid bacteria. So like that he used to tell me. And my classmates used to tell, why you are going and sitting, he's insulting you so much. But doesn't matter, I will learn dermatology and I will help people. So I used to sit there. Even though he used to chuck me out by all techniques, I never went out. So it is helping me today. You see? So center will not be like this. We take a typical textbook picture of. So you will,
yes, ma'am. Lupus valens.
So you will say the hard signs, soft signs, and odd signs.
Odd signs.
So hard sign, anybody can put it as a DD because of the location. Soft sign is the vague edematous face and all soft sign. Odd feature is elevated center. And absence of keratinized margin.
Oh, yeah.
So you should be getting worried. This is not the typical lupus vulgaris.
Lupus vulgaris.
At the end of this case, you will put hard signs, soft signs, odd signs.
Soft sign and odd sign.
Look at the odd sign.
Sure.
Odd signs will give you novel diagnosis. Hard signs will most of the time give you correct diagnosis. You make a diagnosis on soft sign, 100% you will be wrong. Because you see, patient will have some thyroid malignancy, but he will be complaining about constipation. So that becomes soft sign. No?
Soft sign,
if you make a diagnosis soft signs, you will be always wrong. So that is the what you will put below this case. What are the hard signs by which somebody made the diagnosis of lupus vulgaris? Location, solitary lesion, no other lesions. That's a hard sign. Soft sign is maybe some irregular scaliness is there on top of the lesion. And odd feature is
raised center.
Raised, the keratinized margins, which will be spreading like a very dirty appearance. That is not there.
Yeah.
So you make the novel diagnosis of Hansen's disease in this case by picking at the odd features. So that is the clinical lesson in this case. Okay. That's what we should be highlighting. Third, diagnosis, all pathology you can put in one slide. Because time limitation is, all the cases could be accommodated with the pathology which is showing bacilli or whatever, foamy cells, all things in one slide. Because that's the point you are going to highlight. What you will highlight is your colleague pick up the case. That is the point. So under this, that will be hard signs of not saying PPT. Next you show the next case. The next case.
Yes. Yeah, ma'am.
This
is superficial fungal infection, ma'am. Tinea corporis.
Okay. This I agree. You can think whether the patient had a superimposed fungal infection. It is common, no? Scabies, fungal infection, all those things are common, no? Complication.
Superimposed
patient received antifungal agent.
Antifungals has been treating.
Which one, ma'am? As fungal.
We have been treating.
So maybe patient had a dual infection. Because patients look like a fungal only. But I know that I have studied with Chandra sir only. Scabies can complicate. And then it is called Norwegian scabies or something like that, no? Norwegian scabies.
Norwegian scabies in, yes, ma'am, immunocompromised patients. Actually, one case we have thought as a psoriasis and it came as to be Norwegian scabies. Complete scaling of the body and we thought as it is going to erythroderma psoriasis. But after diagnosing the case, we have seen multiple the parasites in the microscope and it is Norwegian scabies.
So that is that I know dual infection is common. Leprosy.
Yes, ma'am.
Leprosy.
Yeah, ma'am. Yeah, that is like beautiful leprosy it is called.
Yes, so those combinations are definitely there. So you only treated it as fungus and these lesions look like fungal lesion. So maybe patient had a Hansen's disease underlying.
Yes, ma'am.
So if there is a poor healing, so here if the poor therapeutic response to proved fungal infection, if it is there, look for an underlying greater thief. My the Chandra sir used to tell, when you see a smaller thief, look for the bigger thief.
Yeah.
When the big thief may be hiding inside. When one disease,
Yes.
it is very common in malignancies. People will develop sepsis,
Yes.
pneumonia, and
Yeah.
you treat pneumonia, patient is
Yes.
not recovering well, underlying malignancy will be there. Like that, that's a dual existence. So here the lesions, to me, I am not dermatologist, you should be telling only. I'm sorry, it is
Yeah.
what I learned from Dambaya sir. No, is it?
Yes. Yes. No. Okay.
So I will say that if there is a proved fungal, even if you have done a clip and proved the fungal filaments, if the response to treatment is poor, think of an underlying immunocompromising lesion, which is making the fungus also to sit on that. So that
Yeah.
will be what I will tell in this. So like that, if you
Yes.
put beautiful points, that will be interesting for the person to listen. Otherwise, I saw atypical features. You see
Okay.
this means everybody will miss.
Yeah. Yeah.
Highlight the learning points.
Okay.
Give the learning points. That will become a award paper.
Yes.
Otherwise, it is not. So each case you have to put the learning point. Okay.
Okay. Okay.
Next one. Next one is
This is granuloma alveolar or erythema multiforme we thought as well.
That is okay. But I don't know. Erythema multiforme can also be a manifestation of Hansen's disease, no?
Yes, ma'am. Yes, ma'am.
So this lesion, I don't know how to.
Yeah, it is granulomatous, ma'am.
But I have seen in the textbooks that this kind of lesions are described.
Yes, ma'am. Yes, ma'am.
No?
Yeah, ma'am.
So any unusual feature you should highlight in this.
Okay.
I don't know, because I have seen dermatology books exactly this kind of lesions.
Yeah, ma'am.
Manifestation of Hansen's disease, they have shown this kind of pictures.
Yes, ma'am.
So if there is
on the hand lesions, actually with that is lichen planus, it is violaceous and pruritic plaque is present, ma'am. LP also it is can be lichen planus also. On the hands, it is like a violaceous plaque with pruritus, ma'am. That will go outside of leprosy.
So that point you highlight.
Okay.
So like that, so what I will suggest, pathology only one slide. Every in between so many, that will save your space. You will change the title appropriate, proper English.
Okay.
And reduce the PPT number by putting one pathology slide. Clinic first patient face, you should put
face. Okay.
And under every case, you put the learning point.
Learning points. Hot points and soft points I will keep, ma'am. So
good. Thank you.
Yeah, ma'am. Thanks a lot, ma'am. Thanks a lot.
So get award and tell us.
Yeah, sure, ma'am. Sure.
Okay. Okay, ma'am. Thank you. Nice.
Yeah.
Good.